Welcome, everyone, and thank you for being here. I'm Jim Bohnsack, and today I get to proudly wear multiple hats. First, I'm the Chief Strategy Officer of TransUnion Healthcare. And then second, I'm lucky enough to be a board member for Socially Determined. And last and most importantly, I get to moderate this session and introduce you to my colleagues. We hope to leave you with some new information today on one, resources to drive efficiency in the identification of social risks. Two, approaches to operationalize strategies to improve health and wellness by addressing social risk. And lastly, how to get started and measure success in those initiatives. So a couple of questions I'd like you to consider before we get started. One is, do you believe social determinants of health impact your members or patients' health and wellness? Two, do you feel like you have a view across your entire member or patient base for social risks? And lastly, are you convinced, and importantly, can you measure the strategies and programs you have in place to create a clear ROI? I'm supposing that we're clear that SDOH impacts health and wellness, but not completely clear on where social risk exists across the entire membership. And from our experience, most are uncertain on the effectiveness achieved in the deployment of our limited resources. So with that as the starting point, and the belief that social risk is that important, how is this our current standard for capturing this important information from our members or our patients? Am I the only one that sees this as a Stone Age approach in today's tech-enabled world in which we live? And yet, to capture this information based on this framework, we're asking our associates or agencies to call our members to capture this information. Do you know what the answer rate is for calls from unknown numbers? It's less than 10%. And then for those that do answer, we want them to share personal information on a 15 to 20-minute phone call. Or better yet, home visits. We're sending people, our associates, into people's homes or agencies into people's homes to capture this information. But I think this is intrusive, wanted. Is it actually scalable to capture this information in that way? Last, they're coming to see our physicians, our providers, right? And we're asking our providers to ask just one more question, right? When they're already queued up, stacked up, trying to get people through emergency room, urgent care, those kind of things. Provider burnout, we know, is a problem. Is it a good use of their time? And do you think we're getting truthful information? So in today's connected world where data is everywhere and captured in every action we take, why are we not harnessing that data to make more informed decisions? With the population at the highest social risk and capturing information one time per year, how long do we think that information is actually relevant? I'm blessed to be in a very stable household in Dallas. Yet back in 2020 in February, if I'd have filled this out in March, it would have been wrong because we moved. And I think of myself as fairly astute in healthcare and technology, but I can tell you from my own experience, when I moved, do you know who I updated with that information? I did not update my bank, and my checking account still work. I didn't tell my credit cards, and my credit cards still work. Heck, I didn't even tell my employer. And you know who my employer then couldn't tell? That's right, Blue Cross Blue Shield of Texas. So we're in a digital age where almost 80 zettabytes of data will be created in 2021 alone. And as I mentioned, I'm in an amazing position with a company that has a massive amount of data. And I'm in healthcare. So every day it's my job to think about how I can get that data in the hands of people like you all who can improve the health and the wellness of the largest number of people. And at TransUnion, we talk about information for good. So how much data are we talking? We're talking about 90 1,000 data sources. We're talking about 4.8 billion updates per month, and we're talking about 1 billion consumer records. That translates into 65 petabytes of live data, and it's event driven. You know, people talk about big data. That is big data. And when I say event driven, here's what I mean. As the example, when I moved, I didn't update any of those individual companies, but when I moved, it was an event. Who I did have to update was my electricity, water, and gas providers. When that electricity, water, and gas providers got that information, I at TransUnion also got that information. So as you think about trying to track the highest levels, those members with the highest levels of social risk, you got to think about how to get the most up-to-date information. We can absolutely segment patients all day long by disease states and by other characteristics, but if you can't reach them, how do we make that information actionable? Well, even with all of this data, we believed that we could bring this to the market and that many people could action upon that data. That was not actually true. So we in turn partnered with Socially Determined, who you'll hear from today, and Ashley on their product called SocialScape. It is a purpose-built data visualization and measurement tool for social risk analytics. And so what does SocialScape give you? It makes this data visible. It allows you to see the contours of social risk in any given service area at a 200-meter resolution, less than a city block, right? Where are the highest dark levels of risk across social risk domains? Housing, food, transportation, literacy. And with the detailed underlying data, you get the geospatial representation, and then overlaying that where your members exist within that social risk. But beyond that, it also gives us a view into the individual themselves and where the social risk exists. So equally important to understanding the environment and the risk contours is the detailed data at the individual member or patient level. And for each of these social risk domains, what are the risks? And importantly, what are the drivers of risk? So if someone has food insecurity, is it due to availability, affordability, or literacy? But clearly the driver will inform what intervention you design and recommend. It's availability, you may design a home delivery solution. It's affordability, it may be a SNAP program or fresh food pharmacy benefit plan. Bottom line, without this data, you cannot make the informed decisions on where to deploy your limited resources to have the highest impact on health and wellness. So in today's fast changing world with people in and out of jobs, very mobile, remote work first, survey data is not going to cut it. So with that as context, let me introduce you to my colleagues. Ashley Perry is the Chief Solutions Officer for Socially Determined, and Brian McClane is the Senior Director of Marketing Intelligence and Digital Products at Priority Health. And they have been on a journey to advance their approach to social determinants of health, measuring and taking action against social risk. And so today, I hope with this Q&A, you'll get some insights into how you can measure, how you can monitor, and how you can get started in addressing some of those social risks. So with that, we'll turn it to questions and stop sharing this presentation. Ashley, start with you. Can you give us some background and your role at Socially Determined and a little about the company?
Yeah, absolutely. Thanks, Jim. So I have the pleasure, as you mentioned, of serving as Chief Solutions Officer, which means I get to work with partners like Brian and Priority Health and their team, specifically focused on taking the analytic insights that come out of the SocialScape platform. So whether that's those community level views of SDOH risk exposure or the member level insights around specific social risk factors and the underlying drivers, and helping our partners think through how do they effectively quantify and then mitigate those risks, both at the member level and for the larger communities that they serve. So great stuff to spend my time on. I'm very fortunate to be able to do it. We'll talk a lot more about what that looks like specifically in the context of our work with Priority in a minute, but I'll just say by way of background and in full disclosure, I'm a public health practitioner and researcher by training, so that is the lens that I bring to this work. So really focusing on helping health systems, health plans, life sciences organizations, foundations, government agencies, anyone who bears risk for health outcomes or who is interested in mitigating some of the drivers of underlying inequities in the healthcare system that we see, mitigate those risks through an analytic-driven approach. That's the work that I get to do. So nice to be with you all.
Thank you for that. And Brian, same for you. Can give us your background and information about Priority Health.
Yeah, so I'm Brian McClane, Senior Director for Market Intelligence and Digital Products. Priority Health is 1.2 million members in Michigan. So we are the second largest health plan here in the States. And we've got the privilege of serving, if I hold my hands up, all of the lower peninsula of the map. So my role at Priority Health has traditionally been in the marketing intelligence analytics space. And a lot of what we're doing is understanding data and how to use it to better engage our members. And I think a little bit over a year ago, we got asked a more broad question about how can we incorporate social determinants of health data in that engagement, right? As we're talking to members about gaps in care or premium payment or joining the plan, how do we understand them at a deeper level than we have through claims data, through the demographic data that we have, but also these social determinants of health data points.
So on that topic, how did you start the journey of addressing social determinants of health? Like what started that for Priority Health, and what was the impetus for that?
Yeah, it's interesting actually going back to those three questions that you asked at the beginning. I'd say, the first one are social determinants of health risk drivers, right? Do they drive health? I think like most organizations, we were all there admiring that problem, right? We all agreed. When you look at it, it makes a lot of sense, right? 80% of all health outcomes are driven by them. The catch was, what do you do with it? And I think in a lot of ways, we were stuck in this world of admiring it as an academic problem, right? Traditional measures like the ADI measures that it's such a large census tract data that it's difficult to bring it down to the individual level to do something about it. And at the same time, as we started to try to dig a little bit deeper to understand community and individual risk, you're looking at, if you want to build a solution, a multi-year approach to get to a point where you really can. So the journey started about a year ago when a group of people came and said, build a social determinants of health data strategy. I have to admit, when they asked me to work on that project, that my eyes kind of glazed over. I love data. I think it's great, but my philosophy has always been, if you're not going to do anything with it, it just doesn't matter, right? It's just something nice to talk about. And so what we started to do as we were working on our Medicaid rebid is to really say, how can we better understand community level social risk? How can we understand it at the individual level? And then how can we put that information into the hands of our team members to help our members, right? Literally start to close the gaps. It's not enough just to know. And so we started with an exploration of building, but then quickly got to the decision that there's a lot of experts in this space today. And we reached back out to socially determined in September, October last year, I think, Ashley, is about when that discussion happened. By January, we had a contract executed. And I think by March, our Medicaid member data was flowing through to socially determined to come back with, and I think you showed those two great graphs earlier, a block level understanding of social risk for our Medicaid population. And what became really powerful was the ability to superimpose members on that, right? The person started to become really, really clear in a way that you never could see them before. I think traditional measures, you look at people in a census tract as if they all are exactly the same and they're all impacted by the social risks around them the same, and that's not factual. Two neighbors look very different. And so, the journey started long ago, admiring the problem, a year ago with trying to start to close these gaps. And today, happy to announce that our care managers are using this information with members to help identify and close gaps. We're working with some other partners as well to get and connect people with resources. But, this work really has been critical in saying this is that person's problem and this is how you can help, where you can help. So.
Yeah, it's fascinating. I love it. Ashley, like when you first started working with Priority Health, where did you guys start? Like, where do you typically start? It seems like, man, there's not a lack of problems to go tackle, but where do you start?
Yeah, it's a good question. So unfortunately, the thing that we know to be true, doing this work all across the country with lots of populations, is that there's no shortage of social need and impact, right? And so the question really is, how can we leverage our analytic capabilities in the platform to help our partners prioritize where do you start? How do you build a roadmap to start to effectively mitigate risk? And how do you make smart business decisions about how you prioritize the resources that you're deploying against that risk? Because you can't do everything for everyone. So the platform and our analytic approach is really designed to help organizations like Priority focus both on communities where we're seeing a confluence of risk and need, as well as high concentrations of their members, right? So that ability to overlay that Brian talked about, member population on top of community risk maps, and find those contours and concentration of risk, focusing on those areas. And then also to think about from an impact perspective. So looking across the different business metrics that you're trying to manage. And it's not just total cost of care, it's also things like suboptimal utilization. So low acuity ED visits, preventable admissions, 30-day readmissions, lack of connection to primary and preventive care, right? How can we start to look at those impacts and understand the role that social risk plays in that? And then also think about things like retention, member engagement, member satisfaction, and other metrics that businesses are trying to manage that we know social risk has an impact on. We can isolate that impact, help prioritize action, and then drive results on the back end when we start to calculate ROI.
Very helpful. Brian, back to you. As you mentioned, we think we understand that there is an issue there and that it needs to be addressed, but we observe it, as you said, academically. So how did you convince the executives at Priority Health to launch different programs or attack this problem?
Yeah, I think the big thing started with really getting agreement in the organization that it is a driver of outcomes, right? I mean, you really do need to start at that first question of the 80%. What's kind of nice is, I use the analogy of they tell you to change your oil every 3,000 miles and you just kind of do it because it's the right thing. Once you establish that right thing, right now, social determinants of health starts to drive you down that path, right? It was easy to say we should do something about it. I think the next part, though, was when we could start to show how it could impact a patient directly, right? The closure of the link, that we were not just going to sit around and have a bunch of data and information. The ability to help our executive team understand and see how you can use it in closing those gaps, right? The discussion of a care manager being able to use it at that level. And even on our side, we're owned by a provider system. And when we're able to have discussions with providers and how they're talking about closing those social gaps leading to getting the patient better, that connection between the many to the one was really a lot of how we started to get forward momentum. And I'll be honest, I think it also helped that many federal, state and local governments are asking, what are you doing about social determinants of health? And they're not just asking in these, as we're serving Medicaid and Medicare populations, do you understand it? They're asking us, what are you doing about it? And help show us the measurement. We're even seeing these same questions pop up into RFPs from employers, right? As they're coming to us, either as a fully funded or a self-funded client. So I think having those other entities that are paying us to deliver healthcare, asking us to do it, helped to gain that buy-in. I'll be open. The measurement side, and Ashley talked a lot to these different pieces, is still a work in progress as far as on the ROI side. But we are starting to be able to show them the value of that too. But luckily we had kind of a snowball effect as we went down from it is important and people want us to address it, and they're clamoring for us on how. So
yeah, how do you answer that question? That seems to be the question we get quite often is, okay, it sounds good.
Mhm.
Wellness programs, it sounds good, but the CFO,
Yeah.
the naysayer goes, what's the ROI? Right?
Yeah.
How do you guys think about that measurement? I'll turn it back to Ashley for the same thing, because I know they've got a kind of perspective on that.
So we're thinking about ROI a little bit differently. Changing outcomes is critically important, and we will measure that, right? But measuring outcomes has a very long slope, right? It can take 2 to 3 years to start to show. And the other problem with measuring outcomes is you're in essence trying to prove something that didn't happen, right? Those can be kind of squishy numbers. If I prevent somebody from getting worse in their chronic disease state, that's a number. So we are focusing a lot on satisfaction, right? Are we seeing improvements in those new members that we're contacting? Are we seeing improvements in how members are viewing our care management services? Are we seeing increased retention amongst those? Even something as simple as once we've engaged a person around helping to close the social determinants of health gap, surveying that member, right? Did you get the resources did you need? Did this, improve your experience? We're trying to really come across those more near-term measurement pieces as we work for, towards those longer-term ones on the ROI about the outcomes.
And you guys are using some additional tools, right? Around referral partners and then language barriers. Speak a little bit about that.
Sure. So when we're calling it a full cycle approach, the first piece back to it is identification, right? Socially determined definitely helps us to understand risk at a block level and at an individual level. At some point, though, we need to start to engage those people, right? And so understanding things about what languages they speak, which is also something that can be served up through SocialScape, right? Starting to understand things about family dynamics. Are they married? Are they not? What we've done is taken the information from SocialScape and we're working with it through a couple of different channels. One is we partnered with Consejo Sano, who really specializes in culturally relevant outreach, right? Knowing the population at that level that they can talk to them in a way that resonates. And they're reaching out to 2,000 of our new Medicaid members every month. What's great about that particular outreach is that that's a population that we don't have a lot of claims data on, but the demographic data starts to paint a picture. And Consejo Sano will do the same thing as the other two streams that we're using, which is connect them with the community partners that we have to help close those gaps, or refer them back to a care manager if there's an immediate medical need. But what's nice is they can take this information, talk to the member, and understand really what gaps need to be closed. The second two pieces are our care managers are using this information in their outreach. And one of the other things I'm really excited about is, we've done targeting in care management for a long time. The idea that you're gonna run a complex formula in the background to determine the highest risk, and you're gonna dedicate your scarce resources to those people. What we're starting to do with our community outreach managers is use the same information or the similar information, but from socially determined to start to triage around social risks, right? Can we raise to the top those 100 or 1,000 members in Medicaid who are impacted most severely by transportation needs? And can we help get them in touch with our resources to do it? It's a very exciting new way of being able to outreach. And again, a big thing about that ROI calculation is being a good steward of the money, right? We don't have infinite resources, we have finite resources. And how do we dedicate them to the right places? I think I failed to mention on the end there, we do work with Aunt Bertha to help connect people with those community resources. And another nice aspect of the data that we're getting and of the community level information is it's helped identify gaps in our social support network, right? If we can see on those heat maps that we've got a high concentration of employees, but no community partner in that area, we're working to reach out to those community partners to help close those gaps.
No, it's super cool. And kudos to those two companies as well. They're awesome. Ashley, I know you guys are partnered with both as well. What are some of the other lessons you guys have learned working with other life sciences companies, payers, providers? I mean, you guys have crossed the self-insured employer groups. You guys have crossed quite a gamut there. What are some of the other lessons you would share around getting started in addressing social determinants of health?
Yeah, so I think that the biggest thing is so many of the organizations that we work with want to be engaged in this work. They really struggle with a lack of a clear view of where to start. And so one of the advantages is we can leverage the Socialscape platform, whether that's at the community level, to think about that existing CBO network relative to the need of the community, and are there gaps there that we need to think about addressing by recruiting potential additional partners or expanding the footprint of those existing CBOs. But also as they start to think about how do they work more effectively together. And the series of partnerships that we've put in place with, Priority, Conseil Sano, and Bertha, and Socially Determined, all working together, right, to create a closed loop, full cycle risk intelligence platform, right, that allows us to quantify risk, to prioritize, to be able to effectively deploy the limited resources that those partners have. And then on the back end, to be able to measure the impact of all of that. It really is the vision for what we're trying to do all over the country, works of partners who can do that work together, and leveraging the view of risk as the starting point for that conversation, but also recognizing, to Brian's point about picking somewhere to start, a metric that matters, and a time frame that works for the team, but being able to then build a roadmap of where do we go from here as we start to see that work build momentum.
What, along those lines, we've talked before, but what are some of the other metrics you are seeing folks measure? Because as Brian pointed out, the absence of an action or something happening is tough to do, except for over time. So I know there's other metrics you guys are using to measure success. What do those look like?
Yeah, so we've talked a lot about the Medicaid population because that's where we start with a lot of our partners. But we think about, and in that case, it might be the retention piece that Brian mentioned. It could be overtime, suboptimal utilization, cost, member engagement. But also importantly, as you think about other lines of business, for example, in Medicare Advantage, one of the big measures that we look at is STARS metric attainment, and the impact that social risk exposure has on that. And can we drive gap closure for STARS metrics, recognizing that there are real dollars tied to that in a way that is accelerated by our ability to generate those insights. We've seen that consistently. What's interesting is that the risk of social, or the impact of social risk across different STARS metrics is not actually uniform. And so different domains impact different metrics in different ways. So surfacing that nuance and being able to empower plans with precise insights that help them close those gaps is really helpful. Brian mentioned the employer space. So there are a ton of employers out there, self-funded employers, that are starting to think about this, not only in the context of their total spend for providing those health benefits, but also in the context of providing more holistic support for their employees in the context of the pandemic and the shift towards remote work and the strain that's come with that. So looking at things like absenteeism and presenteeism for employer populations, employee satisfaction and retention over time, as well as even job performance in seat. So the metrics really vary depending on the organizations we're working with and their primary business drivers. But I would say that the consistent theme is understanding what those are and then being able to inform the strategy around enhancing those performance metrics using the risk analytics as the starting point.
Those are super. I mean, like you said, broad use cases differ by setting and perspective. And I know there's some other, we're working on it with you guys, some other measurements around social risk. Can you talk a little bit about what those are as they're coming down? Not getting you in trouble with the product folks.
Yes. So a little bit of a preview here, but so we look across a number of what we call our core 5 domains. So things like food and housing, transportation, health literacy, and economic resilience. But we recognize, particularly in the last 18 months with everything that's happened, both with the pandemic and the resulting financial crisis, that the world is always changing and risk is evolving. And so to that end, 2 areas that have emerged as really high priorities for a lot of our partners. The first is social isolation and connection, and just recognizing the role that social distancing has had in all of our lives, but particularly the impact that can have on certain populations, particularly in the rural space, actually. And then the second is digital equity. And so as we see the shift towards telehealth and telesupport continue, that is in many ways exacerbating some inequities because of the gap that we see in access to digital services, and also just the digital dexterity is what we're calling it. So the ability to use those services in a self-directed way. So we're working on some models around that right now that we'll be rolling out towards the end of the year, and look forward to integrating that into the platform and the work that we're doing with the priority team.
Brian, I know you're privy to what is coming down the pike, but as Priority Health, you've been thinking about certainly social isolation, the mental health stress and things brought on by COVID. But those additional those populations that you're focused on, how hard is it to understand the connectedness, I will say, of their ability to, like, where do you engage them? How do you engage them? Some on the phone, others now you can text as a health plan, right? Mm-hmm. You know, how is Priority Health thinking about kind of evolving that?
That's another talk in and of itself. And it brings up interesting things too, like express channel of preference versus actual channel of preference. Sure. You know, I often say to people, if you ask me how to get a hold of me, I'll tell you email, because that's the easiest way to ignore you. What really works is a lot of other channels, right? So, how are we looking at it? We're looking at making sure that we've got capabilities to communicate in all of those channels. I don't think people understand the complexity to build an infrastructure that allows you to specify that an email goes through text messaging versus email versus traditional print. The other area that we've been working quite a bit in is trying to figure out, you know, which message works better in certain formats. Information only, right? I'm not going to text you. And sometimes even, you know, not going through a text that tells you to go somewhere else, right? That's always a fun one that we tend to play with. I think, though, going specifically to some of the directions Ashley's headed with SocialScape, the idea of how digitally connected as a person is one that's really going to be paramount for us to solve. And I think about an example of a Medicaid pilot that we ran at one point in time. The idea is if people had a cell phone, right, we could help to close gaps earlier. And we started a program where we were paying for cell phones. The interesting issue we found in the back end was that people weren't buying the data package that was really needed to support it, right? We didn't understand that digital connectedness, and it wasn't until we were way down this journey that we started to see, oh, there's more we needed to do there. And I think where Ashley's heading, that helps. It also helps in rural areas, and people don't think about that a lot. I shouldn't be telling you to connect to a virtual call. I should be offering you a traditional dial-up appointment with a doctor, right? Which still does exist. So, how we're getting there, it's going to be a long journey. Hope that provides a little bit of insight, but also a little bit of the excitement around the places that socially determined's headed.
No, it's awesome. I think we're running up on time here. So before we close out, I'll pose this to both of you. What's the one or two pieces of advice you would give somebody kind of listening to this as they're thinking about where to start with social determinants of health? Let's start with you, Brian, and then we'll close it with Ashley.
Yeah, I would say the biggest thing is just to start. I mean, I know that sounds basic, but this is such a big thing and it becomes so overwhelming quickly. Find a portion of your population, right? And start there. Don't try to boil the ocean all at one time. We started with Medicaid. We kept it with Medicaid. As other parts of the company said, we want to play too, we said, no, wait, give us time, help us to get through this. And then the second thing I would say is once you start, find a way to make sure that you're connecting what you learn with your members, right? Closing those gaps. And again, it can be a couple of use cases, because what's nice is once you get the process going and once you're able to start closing some gaps with some people, it does grow exponentially, right? More and more use cases come up, more and more other lines of business want to participate. So literally just jump off the cliff and get going on it. That's the best advice I can give there.
I love it. Ashley, how about you?
So I would echo that and say, don't let perfection be the enemy of progress. So pick something and start. And then the other piece that's been great about the data assets and the learnings that we have from doing this work is that you can fail fast and figure out what's working and tune your strategy as you go. And I think historically we've had these like very long pilots, right, where it takes us quarters or years to get any results, and then we realize it's not working. And with the data assets and the speed at which we can ingest the data, analyze the data, and visualize it back to your team, we can tune interventions and strategies in a matter of days or weeks instead of months and quarters. So it allows us to be much more nimble and much more focused on figuring out what's working and stopping doing the things that are not.
Oh, awesome. Well, I want to thank you both for your time and your insights. You know, and close it with, we are in a very connected world these days, and this data is readily available. It is being curated and deployed in healthcare use cases that are seemingly endless. And so I would just ask our audience to, you know, question some of the methods we've used historically. For an industry that's still using fax machines in doctors' offices and paper charts, we all have to ask ourselves, is there not a better way that we should be doing this? So with that, thank you both. Appreciate your time and best of luck.
Thank you.